All right. So if you've read and understood considering its surgical pathology station, please tell me after you've read the stem, what are the differential diagnosis you will consider for this
Okay,
patient?
ma'am. So I will go for could be a aortic stenosis, or
Okay.
could be a TB or pulmonary embolism,
All
and
right.
maybe
Okay.
pneumonia.
Low grade fever. Okay. Muscular pain. Okay. All right. Okay. Anything else? Right. Please
Mitral
tell me.
stenosis or
Yes.
aortic stenosis.
Please tell me, how would you confirm your diagnosis? What investigations would you ask for?
Okay, ma'am. So I will do a full blood count. I will do ESR, and
Yes.
then we have to do echocardiography.
Yes.
And then we can do maybe blood culture,
Okay. Right. Any other investigation?
chest X-ray, ECG.
ECG. Yes. Maybe. Right. Okay. Uh, right. Okay. So if you first your diagnosis was a aortic stenosis, what made you think of that?
Okay, ma'am. This could be due to the uh, infective endocarditis.
Yes, all right.
Yes.
This could be infective endocarditis. Please tell me, what is the diagnostic criteria for infective endocarditis?
So we have major criteria and minor criteria.
Yes.
So major criteria, if one is present and three minor criteria, then we can confirm. Or maybe is three major criteria, then we don't need any minor
Two.
criteria.
Yes, just two major
Yes.
criteria.
Okay. And if there is five minor criteria,
Yes.
then we can consider
What about the blood
it's
culture?
positive.
If you can
So blood
describe.
culture, yes, ma'am, we
Yes.
can have a positive blood culture for first 2 hours, and then maybe second blood culture apart from after next 2 hours. Then if the organisms are same,
Yes.
then do we can do the Doppler echocardiography. It is
Okay.
shows like valve dehiscence.
Yes. What would you see on echocardiogram?
So on echocardiogram, we can see like valve dehiscence, and then maybe
Valve dehiscence, but what about the
yeah,
biological valve that patient has? How would they be seen? There'll be vegetation.
yeah, there will be vegetation
Yeah.
and narrowing of the valve. Then could be uh, rupture or chorda tendini.
Okay.
Then rest
Right.
I forgot,
Please.
ma'am.
Yes. All right. What are the common organisms that can be found when it comes to infective endocarditis?
So it can be Streptococcus group, then Streptococcus viridans, Staphylococcus viridans, then uh,
Enterococci and yes.
and the Hatchek
Staphylococcus.
group.
All right.
Hatchek group.
Please tell me this about the infective endocarditis pathogenesis. What signs would you see on hands?
So we have three signs:
Yes.
GNV lesion, then splinter hemorrhage,
What are these?
and
Explain as well, please.
okay, ma'am. So splinter hemorrhage will be a small hemorrhagic lesion just
Yes.
below the nail bed,
Yes.
and then genuine lesion and oslar node. So genuine lesion will be a small petechial rash in the palm of the hand, and oslar node will be like a small ulceration on the index finger.
Please tell me how many types of endocarditis you know about.
We have three type, I think. Infective endocarditis, non-bacterial infective endocarditis, and Liebman-Sack endocarditis.
What about native valve endocarditis? What type of endocarditis is that?
That one I don't know, ma'am.
Okay. Right. What are the risk factors for infective endocarditis?
So if the patient is having any rheumatoid disease, then maybe the patient have family history, then any pre-existing heart disease,
Okay. Just suppose you don't get to
and
manage.
other, yes,
Yes.
maybe like any history of valve replacement.
Yes.
And
All
should
right.
we ask those like congenital heart disease, maybe cyanotic?
Yes. Yes.
Yes.
Right. If you don't get to manage this patient on time, what are the complications that you should look out for?
So if the patient is asymptomatic, then is okay. But if the patient is having mild to severe uh, syndrome, then patient might have uh, shortness of breath, then angina, then syncope, then maybe even death.
Okay. Maybe you can divide them in cardiac and non-cardiac complications, and then you can maybe tell accordingly like that.
Okay, this cardiac complication can be MI, then arrhythmia, and then maybe valvular could be regurgitation and could be congestive cardiac failure. And
Yes.
then non-cardiac, what was it? Maybe it has a stroke. Then
Glomerular.
kidney
Yes.
failure.
Yes.
Yes, ma'am.
Yes. Stroking. Yes. All right. Okay. Please tell me. This patient, just imagine the same lady has persistent infective endocarditis. You try to manage her. First of all, please tell me what medical management you can offer her.
Okay, so we have to give a broad spectrum IV antibiotic, depends
Okay.
on the culture and sensitivity, or talk to the microbiologist
Yes.
for 6 weeks. So we prefer mainly ceftriaxone or vancomycin,
Yes.
and then if is not improved, then maybe we have to go for surgical treatment.
Right.
So surgical, yes, ma'am.
So this patient, what or which blood test would you carry out in order to monitor her disease?
We have to do ESR, blood culture,
Yes, and CRP.
and CRP.
Okay, right. The patient comes back to you. You've given her medication, still she is not responding, and her congestive cardiac failure has become worsened. What management would you suggest her now?
Okay, ma'am. So if medical treatment fails, then we
Yes,
have to go for surgical treatment like valve replacement or maybe heart transplantation.
right. That is the last resort. Yes. Okay, right. The remaining questions are, uh, when you have to consider the heart transplant, what would you think of or be worried about immediately?
We have to consider about the rejection. So
Yes,
before transplantation, we have to match the patient for ABO blood grouping or HLA antigen
yes,
mismatch.
HLA antigen. Okay. When you think of graft rejection, what type of rejection is that? Or what type of
Here it could be the type 1
type
graft
1? Yes,
rejection.
very good. Good, good, nice.